Thank you for inviting me to speak to this important global conference about innovation in needle and syringe programs. I will be referencing learning coming from the Unitaid Hepatitis C portfolio, drawing on the learning of this wonderful... Oh gosh, sorry, I'm going too fast. Where's my... Okay, my slides have disappeared. Okay, I will be referencing learning coming from the wonderful Unitaid Hepatitis C portfolio, drawing on the learning of this wonderful network of partners, which will appear at some point. I acknowledge Frontline AIDS for funding my engagement in this conference and partnering with COACT as a community-led technical support provider. Early in the HIV pandemic, NSP was recognised as a critical HIV prevention strategy with people who inject drugs. It is recommended by the WHO as a core HIV prevention strategy with people who inject drugs and with community mobilisation recognised as a critical enabler. The Global AIDS strategy places a particular emphasis on the contribution of community-led partners to the HIV response. This recognises the need to tackle concentrated epidemics among key populations if we are to ever end AIDS. These bold community-led targets have been signed up to, the 30, 80, 60 bold community-led targets in the Global AIDS strategy have been signed up to by all but 5 countries in the world. The question is whether such bold targets will act as the intended call to action, or whether this is aspirational tokenism. I'm starting to tell the history of peer-to-peer NSP, or P2P NSP, through this speech and through EuroMPOD's technical briefing on P2P NSP, which I'm delighted to formally launch at this meeting. I invite others to help build on this beginning, to deepen and broaden this history from below. Oh, and here is the partners from the consortium that I was looking for earlier in the wrong place. So these are the Unitaid partners that I'm delighted to be working with alongside our community-led allies in input. Oh, and here's the global targets. Things seem to be out of order. So these are the 30-80 targets. My slides seem to have somehow started jumping around. Okay, so the origin story of NSP is P2P NSP. As early as 1981, Nico Adrian and his peers in the Junkersbund in Rotterdam were giving out needles and syringes in the places where drugs were used and sold as a response to hepatitis B. In 1984, MDHG ran the first official NSP, opened with the backing of the Amsterdam government after a pivotal pharmacy NSP withdrew from dispensing needles and syringes, leaving municipal authorities to fund a fixed site NSP given concerns about the emerging HIV virus. Despite these peer origins, NSP was to become a largely professionally delivered function in the Netherlands. My own country, the UK, is often described as one of the homes of harm reduction. And it is the city of Liverpool that lays the strongest claim to this moniker. Liverpool was one of the 10 pilot sites in the UK that were included in the study running from 1987 to 1990, overseen by Professor Jerry Simpson. The Liverpool and UK response more broadly is often described as a professionally delivered model of NSP. However, these photos from the pioneering age of NSP in Liverpool indicate that there were harm reduction workers such as Alan and Lynn Matthews, who are now able to talk more openly about their own drug use at the time. Peter McDermott was a trusted advisor as an injecting drug user to the then regional drugs and HIV coordinator, Pat O'Hare. However, the risks of operating as an open injecting drug user and being an academic was well illustrated by the struggles of Dr. Russell Newcomb, despite him providing one of the world's first definitions of harm reduction. Even within the UK's mostly professionally run NSP model, there were some community-led interlopers. The Healthy Options team was the community-led harm reduction service that survived for 16 years from 1988. HOT employed a community development approach that I learned from the gay HIV activists in Brighton. HOT also inspired Keith Bolton, a health promotion officer, to set up a community-led P2P NSP with Nikki Coe and her peers in the seaside towns around Colchester and Clacton. However, despite being positively evaluated by anthropologist Annette Walling, the police arrested most of these uppity junkies once the lead staff member left his post. The most common form of P2P NSP in the UK through the 1990s was secondary NSPs, where key local people who inject drugs supported fixed-site NSPs to reach out. Helen Fletcher and her husband opened up their front room in Moss Side as Manchester Main Line. The Scottish Drugs Action Group member groups distributed needles and syringes to their peers in places such as Edinburgh, Dundee and Ayrshire. However, despite harm reduction successfully containing the threat of HIV among my country's people who inject drugs in the 1990s, the British model was on life support by 2015. The devastating double punch of 25% cuts under austerity from 2008 and the imposition of a distortion of the recovery model to justify these cuts saw harm reduction sidelined and the highest drug-related deaths in Europe and a new HIV outbreak among people who inject drugs in Glasgow in 2015. Shame on the home of harm reduction. This context meant the UK was ill-prepared to deal with the COVID-19 pandemic. Needle and syringe coverage dropped by 25 to 50% during the lockdown period, and this decline has proved stubbornly difficult to reverse. However, in my hometown of Bath, Respect P2P NSP, Respect is our group, has for 4 years distributed 1,500 needles and syringes per month through 10 to 15 local drug suppliers and peer leaders who distribute on a cascade basis to our local community. We distribute 80% of the local distributed equipment on a volunteer basis and have faced repeated refusals to pay £2,500 per year for an incentivised peer education programme. However, it is also important not to forget another critical exception to the UK rule. In Northern Ireland, Buff Cameron has used his trusted position first as an outreach worker and later as a senior manager in the NGO Extern to develop an exemplary model of NSP in Belfast and beyond. The Belfast NSP is a standalone service in the city centre, which exceptionally in the UK operates 24/7, and many staff have peer-led backgrounds. However, community NSP doesn't need to exist on the margins as volunteer programmes or reliant on exceptional managers. In 1989, Divo in Dunedin in New Zealand became the first state-funded NSP founded and staffed by people who inject drugs. The story of Divo was recently retrospectively documented through a really interesting collective community writing project that led to an academic article written by Professor Magdalena Harris, who started out as a 17-year-old peer worker at Divo. Divo was not alone, as the New Zealand Needle Exchange Programme, coordinated previously by Charles Henderson and now Jason George, brings together 21 fixed-site P2P NSPs, which provide 95% of the needles and syringes in New Zealand. These peers are less explicitly seen as drug user groups, despite being community-led NSPs. In Australia, the wonderful AVIL network brings together 9 drug user organisations, 6 of whom operate one or multiple P2P NSPs, AVIL nationally and its state member orgs provide comprehensive peer-led harm reduction, such as AVIL's hand-washing campaign that was incorporated into the Unitaid Safer Injecting course. Drug user organisations are often the best ambassadors for harm reduction, both within our communities and outside to the general population. How different the UK story could have been had professional partners defended the drug user rights movement back in 2004, then you would have had allies to fight for you. First they came for the drug user rights movement, then they took out harm reduction, a lesson that the professional sector really ought to learn. Without diminishing the many challenges faced by drug user organising down under, our Australian peers have earned themselves a key role in the front line of the response to viral hepatitis among people who inject drugs. AVIL's pioneering work demonstrates the potential contribution of community-led organisations with systematic investment and respectful work. However, it's not always strategic for community-led organisations to openly identify themselves when faced with extreme criminalisation. The activist roots of NSP in the USA were clear from the start. Struan Parker formed the National AIDS Brigade in 1985 and is credited as the first person to distribute needles and syringes in New York. And I'm sorry, I don't have a photo of him, but we will share it another time. Part of the joy of this work is we're gathering this history together. While many of the NSPs across the USA were staffed by people with lived and living experience, most chose to publicly identify themselves and organise through the National Needle Exchange Forum run by Dave Purchase. An improving policy environment has seen drug user activists starting to organise more openly together through the Urban Survivors Union. Louise has been a key advocate about the devastating impact of the toxic heroin supply in the USA. Across North America, frontline dedicated needle slingers have sustained NSP in the midst of a murderous poison drug supply crisis. I have picked out Jess Tilley and her peers at the New England Users Union to illustrate the dedication and service of these community heroes in the US and Canada who have served their communities despite losing long-loved and respected leaders like Dan Biggs and Rafi Balim. Jess and I shared a love and respect for Mark Kinsley, who was another harm reduction pioneer from New York. Mark was working with the Yale School of Public Health, tracking needles and syringes with code numbers on them in and out of the drug-using community. This allowed for early pioneering research that provided critical evidence for NSP and demonstrated the role of peers in brokering or delivering research within active drug user networks. Credible evidence is key to informing WHO policy and technical guidelines. These are coming up in the wrong order. After a successful career as an executive director of AVIL, Dr. Annie Madden retrained as an academic. Annie has championed a values and preferences research model which ensures that the voices of people who inject drugs are systematically captured in research studies. So compelling is this research model that it has been adopted in the master protocols being used across all three Unitaid consortiums. Congratulations to Input for the advocacy. COACT is happy to bring our community expertise to support a number of academic studies undertaking research with and about people who use drugs. We recently worked with Queen's University Belfast to capture the voices of over 40 drug user experts in an eDelphi study that is setting quality standards for the evaluation of DCRs. We are reviewing academic studies and supporting guideline development is often a dry and time-consuming and laborious process, but it sets the standards and good practices that ensure our peers receive the right to health. Judy Chang coordinated the development of the I Do It toolkit that presents UN guidelines in a community-accessible format. Now as Executive Director of IMPUD, Judy advocates for those standards through global health. We are in exciting times when even a professor can acknowledge her pride in membership of our community. What a change from the times of Russell Newcomb. The impact of WHO policy documents is demonstrated by the Federal Ministry of Health in Nigeria's NSP pilot in 2019. They followed global guidelines and chose to trust their NSP pilot to 3 community-led NGOs. Global Fund Investment supports accepted good practice, and Frontline Aid shared their programming expertise as an international NGO and hired COAC to work with local partners to design and deliver the implementation training. More experienced programmers and the Ministry of Health all played key roles to facilitate the community-led delivery of NSP through drug-using hotspots. Nigeria is blessed with some wonderful community leaders. Anidi Akpan, with the baseball cap on, is both the ED of DAPO and has helped establish the RAN network as a key coordinating network for many of the community-led drug user organisations in Nigeria. IMPUD provided Duran with long-term technical support through the Global Fund Community Rights and Gender Programme after COAC support through the NSP pilot. All credit goes to all of the amazing peer outreach teams and their leaders on the ground, but the value of sustained community-led technical support is evident. I want to draw some attention to some of the specialist functions of NSP, once again using the lens of P2P NSP. Massimo Luzzo and Cristina Simeonato, hot 2 Italian outreach workers, demonstrated their ability to use their privileged access to navigate through East London's hidden Italian drug-using community, a success that was repeated with many other migrant populations. Janko Balin from Ariel Tribe, a community-led NSP and informal DCR, ran for several years in Slovenia, operating from a collective squat, helping those on Europe's harsh migrants trail manage their drug use in a place of love and safety, only stopped when they demolished the building. Yasir Ali Khan from HIV Buddy in Pakistan used online dating apps to reach out to MSM seeking chemsex hookups, offering access to needles and syringes, harm reduction advice and HIV testing, based on interpreting the coded emojis and insider language used by people who inject drugs on apps. Diana Edam from Lagos champions the needs of women who inject drugs within the NSP pilot, highlighting the challenges faced by women who need to navigate police corruption and gender-based violence to access NSP provision. Let me highlight 4 examples of P2P NSP in high-risk settings. These community heroes show what is possible with privileged access, love for community, and incredible courage. Georgia had extreme criminalisation. Police could instruct someone to go to the police station for a drug test, and they would receive concurrent sentences for each drug that they possessed in their bloodstream. Lasher and the team at GEMPUD used their privileged access to both distribute NSP and step up in public to undertake the necessary community-led advocacy. In Kachin, in Myanmar, Ko and his peers at Pure Balance Mind drug user group deliver needles and syringes across conflict lines in the war between the Burmese military and the Kachin Independence Army. Pure Balance Mind has an MOU with the KIA, allowing them safe passage to undertake their work. In Cebu City, Abdul Rahim Rahaji and his amazing team at Bridge Hope Health Organisation in Afghanistan continue to brave the changes in the government and navigate the Taliban's strict moral code to serve their community. In Cebu City in the Philippines, I Do Care has delivered P2P NSP against the backdrop of the extrajudicial killings of over 25,000 of our Filipino sisters and brothers. They quietly and discreetly deliver P2P NSP, avoiding the informers and executors. Looking to the future, we see the use of a range of dispensing machines. This smart machine in Georgia gives out a range of needles and syringes, testing strips and drug checking materials for those with smart cards, while looking and operating as a commercial pharmacy sales system to everyone else. Igor and Alexei from Drug User News use their credibility and profile as drug user video advocates to engage people who inject drugs on a Russian dark website with over 1 million users. They sent out needles and syringes and HIV self-test kits to people who identified as drug injectors and trusted them with their address. Innovation doesn't always need to be high-tech. In Kachin, local shopkeepers were paid to distribute paper bags of needles and syringes for a fee that gave them a stake in local harm reduction. And this is a photo of EuroEmped running a technical webinar organised by COACT for Nigerian community-led DAPO and their government and state partners. Prolar from Norway and GAP from Portugal and their medical allies explained the community-led point-of-care testing scheme and recognising that community-led technical support both teaches and inspires. So I'm going to have to jump a slide. We have lots of new technology, as you can see. We need to move away from oversized equipment so that we can start purchasing the right equipment to maximise our investment. But we also need to make sure that we get enough needles and syringes to people so that actually the right equipment makes a difference because it's there in enough quantity at the right times. We also need to recognise the range of other equipment that we need to give out. And my just two last points. The future of NSP is community-led drug consumption rooms. PWID have always been clear that highly medicalised DCRs make people feel unwelcome, and too often staff are experienced as judgmental. The wonderful GAT DCR and the range of Canadian DCRs, symbolised by Matt Bond, challenge the sector to invest in small, dispersed, attractive community-led DCRs and to take this opportunity to let communities lead and receive new investment. Just last point.
It's okay.
Finally, we come to the issue of funding, which is why I would just like for you to indulge me for just one more minute. This is a story of peer-to-peer NSP receiving a tiny percentage of the limited funds for harm reduction. The community-led targets 30, 80, 60 require high-level funding changes by donors and programmers, but it also requires every one of you to make decisions in your work to let communities lead, sharing money fairly with your community-led partners, ensuring our organisations are sustainably and fairly funded so we can have the required influence on the system that your targets require. And of hardest of all will come the times when you need to step back and give space for us to run our own NSP, as is clearly required if we are to meet the 80% prevention targets in the Global AIDS Strategy that all your government signed up to. As you leave here, I ask each one of you, what will you do in your work to ensure that the communities are really able to lead, unless the 30, 80, 60 targets were only meant to be symbolic but not implemented? Thank you.
Thank you.